Let's talk about head injuries. Before we get into it, I want to differentiate between the head injuries we're going to talk about right now and head wounds, meaning cuts on the head. We're going to talk about head wounds or wounds in general when we get to soft tissue injuries. What I'm talking about now are head injuries that are causing brain trauma. That's what we're concerned with. When we get to head injuries, this is not something you want to mess around with. I'm going to give you one overriding factor, one thing that you're going to think about and look at that will determine everything else you're going to do. That is mental status changes. If you have a patient who has an incident where they have a known or suspected head trauma, and they have, again, known or suspected mental status changes at the time of the incident or post-incident, that is an immediate evacuation. Your trip is over, you are leaving the woods, you are getting out. We have no way of dealing with brain trauma in the backcountry setting. We also have no way of knowing the extent of the problem in the backcountry setting. Head trauma can look minor. You all heard the term, oh, they just had their bell rung. Oh, they're just seeing stars. Or, oh, it's just a concussion. Those are not good sayings. That's not something you want to think about. If a patient has an incident of head trauma with known or suspected changes in mental status, it is an immediate evacuation. You are getting them out. Why are head injuries so bad? Well, your cranium, your skull, has a finite amount of space in it. That space is under a constant pressure. Remember, your brain is very sensitive to any minute changes, pressure being one of them. We have to maintain this pressure at a constant level to ensure that we have good brain function. If that pressure changes, things can go wrong very quickly, especially if that pressure goes up. What you have to think about is if I have head trauma, I have the possibility of rupturing blood vessels inside my skull. I can rupture them in the brain. I can rupture them in the membranes that surround the brain. If blood starts to fill up the skull, that pressure increases. As that pressure increases, it starts to put pressure on the brain, which is going to have a lot of bad consequences. We'll get there in a second, but let's move through some of the progressions. First off, let's address concussion. The reason why I said I don't want you to say just a concussion is because it's not just a concussion. In fact, I want you to forget the term concussion altogether. A concussion is a medical diagnosis. It needs to be made based on very, very specific tests. People get concussions. Concussions can range from very mild all the way to very extreme. But you and I are not able to diagnose how bad a concussion is. What I want you to think about is someone had head trauma. They had an incident where they whacked their head. Maybe it's a concussion, but a concussion is brain trauma, and I do not know the extent of that. If we say, oh, it's just a concussion, what happens is we tend to minimize it, and that means we don't give it the attention it deserves. All I want you to say is, this patient whacked their head. I am going to assess them and monitor them for head trauma. Now, what kinds of injuries can I get? I can get two types of injuries to my head: open or closed head trauma. Now, as I said before, this is not a wound. A wound is a soft tissue injury. When I say open head trauma, what I mean is that the skull has actually been cracked, that it is open to the atmosphere. Open head trauma, closed head trauma. When I'm assessing someone's skull to see if they have an open cranial fracture, I'm feeling and squishing and squeezing. What you might feel underneath your hands as you're doing that is a boggy sensation if someone has a fractured skull. You might feel your fingers kind of push as if you were pushing on moss. If you feel that, stop. You know you found the injury. Don't keep pushing. If you're looking around and you see exposed brain, you know you have an injury. You don't need to tickle their brain and see if you can get their left arm to move. You've found the injury. Closed head trauma just means that they haven't fractured the skull. It means that the injury is internal with no external signs. All in all, though, what are we looking for? Mental status changes. A person who has head trauma needs to be monitored for mental status changes. any mental status changes. Now, one of the things that we think about with head trauma is how this person might act. And there's an acronym we use. It's called DICC. This person may act like a DICC. D-I-C-C. What it stands for is disoriented, incoherent, confused, and combative. Meaning they might be disoriented. They might not know what's going on. They might not recall all the events. They may not be sure of their surroundings, may not remember their name. Confused. Simple enough. Incoherent. They might use mumbling words. They might use inappropriate words. They might not make any sense as they speak. And combative. These patients have a tendency, as it progresses, to get angry, to get combative. Disoriented, incoherent, confused, and combative. These are signs of head trauma. Again, this is a range. You can have from very mild to severe. What else might happen as this person progresses in a head trauma situation where the pressure inside their skull is going up? Well, as it starts to get bad, you start to get breathing changes, meaning their pattern of breathing is going to vary. They go from breathing normally and regularly to irregularly, to very rapid, then very slow, to deep, then shallow, to all over the place. But by the time you have breathing pattern changes, you know that you have progressed pretty far in this process. Finally, you might get pupillary changes, where their pupils actually change and they don't react the way they did and they didn't have head trauma. But pupils are a very, very late sign. By the time head trauma has caused pupils to change, you know that your pressure inside your skull is extremely high. Do not wait for someone's pupils to change to say, oh, I think they have head trauma. Now, how might the pupils change? Well, the classic sign is you have one pupil that's normal size and one pupil that's blown or very big. If you see that after an incident, you know things are bad. You know you have to move quicker. But the most important thing that you can think about when it comes to head trauma is mental status changes. If you have known or suspected mental status changes when an incident occurs, it's an immediate evacuation for possible brain trauma. But what about the person who has an incident who doesn't have immediate mental status changes? What do I do then? Well, I need to monitor them. You may have heard about not letting someone go to sleep after they had head trauma. Well, that is correct in one way. It's not true all the way through. If I just had head trauma and it's 7 o'clock at night, I don't want to stay up for the next 24 hours. I'm probably going to be very tired. Why is it said, though, we don't want to let them go to sleep? Well, if I let someone sleep for the next 8 hours, I can't monitor them. What you might need to do is say, all right, you can go to sleep, but I'm going to wake them up every hour. Ask them a series of questions to make sure they are not having increased pressure inside their brain. And I'll keep doing this. If they never progress, then it's fine. Maybe we can keep going. But if I at all think that there are changes in mental status or they have an increase in pressure in their brain, I'm getting out. Because ultimately, at the end of the day, if the pressure continues up inside their skull, what will happen is they're going to herniate their brainstem out the bottom of their skull and they'll die instantly. And I don't want that to happen. So how do we treat this? Unfortunately, there's no treatment for this in a backcountry setting. What we have is palliative care. We're going to treat signs and symptoms. If the patient's having a hard time breathing, we're going to support their breathing. If they're disoriented or they're falling down, we're not going to let them walk. We're going to carry them out. We can't do anything beyond that. We monitor, we watch for mental status changes, and we evacuate them. That's all we can do. Don't get it in your head that you're going to take your Swiss Army knife and do a borehole inside their skull. We don't do that. You're going to monitor, you're going to do palliative care, and we're going to get them to definitive care because that's what they need.